blocks with ultrasound when we started doing it with Dr. Vieira. This was a non-existent field in our specialty. When the old Maple building opened, we had to figure out how to do nerve blocks without ultrasound guidance. It wasn't standard educational chapter or rotation when we did anesthesia trainings. They called me the king of blocks when I was a resident, when I graduated from 1997, because I did 3 interscaling blocks during my residency. Entire residency, 3 years. So people didn't know how to do blocks because they tried, but more frequently they failed than succeeded, and they run into complications. And they could put everybody to sleep, and so the regional anesthesia was one of the stepchild in our field of anesthesia. And when NEOS had this agreement with Bay State that, okay, you guys can have your own outpatient surgery center, let's give it a try, a small place. The recovery room was like how big? Like
6 days.
6, and for 4 operating rooms, right? So we had to figure out how to discharge patients from the unit after bring them in for shoulder surgeries and ACLs and things like that. And Dr. Vieira and myself, we were both pain doctors, so we had some experience with needles, but not with peripheral nerve blocks. We started to kind of figure out how to do nerve blocks without it. It took us some time. Just a reminder who worked there. The very first Garris patient who had a shoulder booked as a first case, 7:30, was in by 6 o'clock, so because we needed half an hour to do an interscalene nerve block with a nerve stimulator, right? And then we started to hear about in certain places they started to use ultrasound for nerve blocks with Dr. Vieira. And we went up to Dartmouth Hitchcock for a weekend just to look around what they were doing. And we heard kind of a nebulous and not too specific lectures about what they are doing and how they were doing, but very few specific clues, because clearly they were talking about it, not doing too many of them. And we managed to convince that provost to buy an ultrasound machine, a small sonocyte ultrasound machine, and we started to look at patients' necks and arms and things like that. And we really didn't know what to do with that. That's the fundamental problem with ultrasound, right? It's an extremely powerful tool, yet very few people just go there, turn it on because I need to find a vein. First of all, way too many knobs there, right? Very confusing, so you don't want to mess it up. And once you hold the probe in your hand and you put it on the human body, what you are looking at is not intuitive. We all had anatomy classes, so we all see the human body being exposed during surgeries, yet when you look at that image, you just cannot relate to what you see there normally, right? In other words, you have to train your brain to identify anatomical structures with the ultrasound. And in terms of how good you are with it, a lot depends on how good with your hand, because the image quality depends 90% of how you are handling that probe. So we started to do ultrasound guided blocks, and we really made some progress. Sometimes we hit it, more frequently we missed it than hit it. And then we went to one of our national meetings, and General Electric had a display there with this particular ultrasound machine, and we put it on the body. It was just like a revelation, because now we could see much better everything we were looking for. And General Electric was the first company that had a good enough software. So when you use an ultrasound, this brings us to this topic about how the ultrasound works, right? Ultrasound is basically, it's a sonar, right? It sends high frequency sound waves out, right? It's in the megahertz range, so it's an order of magnitude bigger than the frequency that we are hearing. And it's like a sonar, so it hits the tissues with high frequency wave, and it waits for the signal to return. And from the returning signal, it tries to generate some image. And the longer it takes the signal to return, the further down on the screen it's gonna be displayed. And to start with, it's an extremely difficult signal to noise ratio to deal with. In other words, there's a lot of garbage and noises coming back from the field that ultrasound would sends out. And this is why when you look at an ultrasound image, we have an idea about the graininess and everything else of the ultrasound image. This is why we kind of cannot interpret and see what's there. So it takes a huge amounts of wizardry, software enhancement like filters and all kinds of cross-beam technologies to get rid of the artifacts and to see what we really want to see on the picture. And GE was the first one and still one of the leaders of software development when they cracked this and they could give us like very close to normal life anatomy that we can see with the ultrasound pictures. You may have noticed that we have another type of GE machine. Software is exactly the same in that machine. Just when the tablets and the touchscreen technology was becoming widespread, and they wanted to get rid of the expensive part of manufacturing the keyboard and modifying the laptop computer, they hired an Israeli company just to generate a touchscreen software. Otherwise, everything else is pretty much the same in that machine than in this one. So when the ultrasound uses a 2 to 14 megahertz frequency range, right? We use two probes with this ultrasound machine. We've got a big curved probe, and we've got the smaller one linear probe. And we don't use it here, but there are some small hockey stick probes that we use for pediatric ultrasound examinations. And depending on how they are lining up the crystals, it's either a linear probe, like that 6 centimeter probe, or a curved probe. Simply they are just putting the crystals along the curved surface, so when they shoot out, they can scan a bigger area. The ultrasound at different frequency range behaves in a different fashion. The lower the frequency, the deeper it goes. However, the returning signal is not as sharp, right? So you can survey a larger area, you can get more information back, but it's not going to be as crystal clear. The higher the frequency, like 8 and up, we use most of the time 10 to 12 megahertz, the higher end with the smaller probe. The shallower the penetration is, but the better we can see the targets, right? For nerves, 10 to 12 is pretty much what we use. And when we have a bigger patient and we have to see like 8 centimeter deep, that's pretty much the end of how far we can see nerves with good quality resolution. Because to begin with, it is like driving in a snowstorm. That's the original raw image is all about. So this is why it takes a lot of computational wizardry to basically generate us some good images. And most of the ultrasound that goes into the tissue is kind of wasted, right? Some of it just travels through the tissues, never returns. Some of it is just absorbed by the tissues, it just generates heat. Some of it is being like deflected, and when it comes back, a structure that wasn't originally in the path of the probe is basically coming back, just generating noise. And when the ultrasound travels through a homogeneous tissue, like a blood vessel, you have no reflections. Reflection always happens when the ultrasound reaches a different echo-dense area, right? And the bigger the difference between the solid and the water phase of the tissue, the more reflection we have. So this is why blood vessels look perfectly nice, because it travels through some nice blood-filled cavity. Originally, ultrasound was used to find all kinds of cystic problems in the liver, kidneys. That was the original use was back in the 80s and the 90s. They could find some cysts that X-ray just wouldn't pick it up without any contrast material. And some structures like bone, they are like a wall. When an ultrasound hits it, it bounces all back. In other words, you cannot see behind, right? And behind the bone, what we have is called an ultrasonic shadow. It looks like there is something there, but the ultrasound doesn't go there, so you have no information. People, when they try to drive the needle there, they think that they're looking at the needle, but there is nothing coming back from the needle. So that's how people, when they do neck injections, they can put pneumothorax and all kinds of stuff, or working on the ribs, because they cannot really see behind the rib. Okay, what do we have next? So, I'm gonna jump over to the machine because that's the part that sometimes we ask help, just why don't you just do this with the machine, do that with the machine, because our hands are busy, right? When we are doing nerve blocks, one hand is the cameraman, and remember 90% of the image quality lies in the hand that holds the probe, and the remaining 10% is how we are setting up the machine. The probe that we use is a 6 centimeter probe. It's called a linear probe. This one here. There are like a couple of hundred pairs of crystals lined up in a straight line like this. Each and every one of those crystals, they shoot out ultrasonic energy right straight down, a couple of hundred times per second, and then they shut down and they wait for the signal to return. And from the returning signal, they generate the image, right? When you use the bigger curve, the curvilinear probe, it's pretty much the same idea. That's an arc formation. So they spread out like this. Obviously, they can see a bigger image. The first confusing part about this is what kind of image we are looking at here, right? You put it over the body, and what is the picture that I'm looking at the screen? The easiest way to imagine this is, imagine that this probe is a putty knife, right? It's like so imagine there is a shiny stainless steel square shaped metal coming out of this, right? You put it over the arm, and now you are inserting the putty knife into your body, right? And then you are looking at the reflective surface of the putty knife as a mirror. That's what you see here. So when I'm putting the probe on my arm like this, right? It's like I put the putty knife into my arm, and I'm looking at the human tissues on this side of the shiny face of the putty knife. That's what I'm looking at, right? First and most important button on this one is the power button. We need to start somewhere. Sometimes, I was on call for, Noble, and they brought an ultrasound machine in from and I never used that, right? I know that the basic principle is the same, just like you have a rental car and don't know how to start up the car because nobody should. So it could be confusing, but it's clearly marked here. Important thing about the battery, right? This is like a laptop from 15 years ago. You hear the fan going on all the time, which means it uses a lot of energy and dissipates a lot of heat. So the built-in battery is not going to last long. So this is why this special stand comes with a secondary battery down here, right? Now, they are connected, so there is not much we can do about the connection of this one and this unit. But this unit, every computer has an idea about, just like a cell phone, how much juice you have left in the unit, right? But it only applies to the one that's in this machine. It doesn't monitor how much juice you have left in the bottom unit. So this is why I keep it plugged in most of the time. It's a pain in the butt when you are doing the procedure, patient is sedated, and the machine gives you a warning that, I'm running out of juice. And then you start looking for why we're running out of juice, because this doesn't know that this is already almost depleted, and that one is just stopped giving any more juice out. Because the plug in the back here got pulled out while we are moving it. Number one reason why it's not working, right? So it has this metal clasp, and make sure that when you plug it back to the wall, that clasp is on, because then the whole unit is juiced up. Also, if you see this with green colored illumination, it means that it's properly plugged in. If it's not plugged in, you're not going to see this here. It's possible that the printer is not turned on, but that's how you can tell that the whole thing is under proper electricity supply, and we're not going to run out of it, because once it shuts down, takes like 2 minutes to boot up. This is when it becomes a pain in the neck when you're doing the procedure and runs out of juice, shuts down, patient is sedated, needle is there, we are halfway done with the block, and we have to find where this is, have no electricity, and why this is why before in the OR I get started, I make sure that I have electricity there properly, so it's not gonna fail me. So that's the power button, right? The next most important one is, and most of the time that's the biggest button, is the brightness, right? On this one, we've got a big rotary knob here. It's just like brightness on your cell phone or your TV screen. You pick the right amount of illumination coming out of the screen so you can see what's going on. Typically, the deeper we want to see, the more energy we need. So if we go deeper with the ultrasound machine, without adjusting the brightness, it gets darker and darker. Because if we send out the same energy from the probe, obviously the more it has to travel, the more absorption we're going to get, so the less energy and information is going to come back to the screen. So we have to increase the brightness. So it is an automatic move. When we are changing the depth with the ultrasound probe, we are adjusting the brightness. Also, by adjusting the brightness, we can see nerves or structures that we are interested in more or less. Typically, I mean, this is a black and white screen, so we have structures that are white, called equidense, and we have structures that are dark, echolucent. Blood vessels, cysts, there is nothing in there. Local anesthetic that we inject, which is fluid, it's dark. And nerves, typically, they tend to be very bright, so that's what we are interested in. Too bright, it's like putting your high beam on when you're driving in the snowstorm. You're not going to see much. Too dark, you are going to miss stuff on the screen. So you always have to adjust and find the right amount of the gain. So this big one is the gain, that's the brightness. The next really important one is the depth, right? You want to see your target on the bottom third of your screen, so you can see the needle as it's approaching it, right? And it obviously varies depending on what we are looking for. If we are looking for a sciatic nerve in a big patient, or we are doing hip blocks on a 120 kilo patient, things could be as deep as this. So if we set it off for 3 centimeter deep, you're not going to find anything. So you always want to find the right depth. So we've got the power button, we've got the brightness button, and we've got the depth button here. Remember, every time you turn the depth on and go deeper, you have to increase the gain because it's going to get darker. So it's almost like an automatic move, you know, how you set this up and how you visualize your picture here. The other knobs that very, very frequently got messed up when we are cleaning the machine. These small toggle switches here. They call the time-gated channels or time-gated switches. What you can do with these toggle switches here, that imagine that every 1, 2, 3, 4, 5, 6 we have on this machine. So basically you have 6 horizontal bands on the screen, right? The bottom one controls the bottom 6. The one above controls the fifth part of this. So each and every of these controls only one segment of the screen. It's a long story why we need this, in essence, because the speed of the ultrasound varies from patient to patient, and the preset gain that's in the machine is not perfect for every patient. So we can adjust, if the nerve I'm working on is in the bottom part of the screen, I might need more enhancement and more amplification in that. That's what I can do with this. So when you clean up the machine and they look like this, when this is pushed over to the left side, that segment is not even working. It's just like turning off that part of the screen. And frequently when I was teaching residents, I messed it up a little bit because they have to go through a routine check of the machine to see if because they cannot find what they were looking for. Very simple, because I knew where the nerve was, and when they pushed this part of the switch this way, the nerve is not even visible on the screen. So they have to they have to be able to troubleshoot it. The best way to set it up, to keep the top 3 in the middle and push them further to the right on the bottom end, and that's probably the best setup. For superficial nerve blocks, doesn't matter much. The deeper we go, like 3, 4, 5 centimeter depth, the more you have to play with that. Focus, that's an interesting story. That was an excellent question for me to test if the residents, they read the appropriate chapter about how the ultrasound works. Because people who reached the 40th or the 50th page of ultrasound physiology, they got the answer to that one. So it was a good selector for the well-prepared, between the well-prepared residents and the less well-prepared residents, but it's really not that important here. So basically that's about the machine part of it. And when we are working and both hands are tied, sometimes we ask just to push the P to a print button, so because we have to document what we are doing, right? But that's just about it. Again, extremely useful, and starting IVs, ladies in the back too. If you ever cannot find the vein, you can always find the vein with this. Always, always. Turn it on, go to 2 centimeters. 2 centimeters, you don't need any more than that. Use a lot of goop, right? And when you have because if you don't use a lot of goop, you're gonna compress the vein, right? So just touch the skin through that, and figure out which is left, which is right. Just touch see when I'm touching this part, see? You see my finger touching that corner there? That's left, that's right. and you put it over your arm and see that big aqualucent structure, this could be practically, it's a blood vessel or a cyst, right? It's not a lymph node because there is nothing in the middle, but when I'm applying pressure, see how I'm compressing it? And it doesn't pulsate, right? That has to be a vein. Now, see that yellow arrow in the middle? That shows the very center of the probe, right? So if you have, and actually a corresponding, like a triangle here, it's not yellow, it's gray, but if you see that yellow triangle on top of the target, and you look at the same gray triangle on the probe, the very center of the probe on top of the target, right? And if you move your probe up and down, see, I see how they split into two veins, and this just decided to marry with this one here, now it's another one. And now it dives again and it goes deep. So by moving the probe up and down, you can see which way the vein moves. Because if I'm moving it up and down, and my vein stays underneath, you bet it's right under that, it's straight. If it's moving to the right, it's gonna be moving across. And then I turn the probe if it's moving across, and if it stays in the middle, I know that it's moving across, so very precisely I can figure out which way the vein goes. You can mark it for yourself with a pen, but at least you have an idea where the blood vessel is, and you can have an idea about the depth. Learning how to drive needles or any tools with the probe takes a lot of practice, right? Finding a vein with this one, it's not too difficult. That's how you get comfortable with the machine, right? You pick it up, oh, I've got a vein here, I figure out which way it goes, that's great. Learning how to start an IV, could be more complicated and more difficult than learning a simple nerve block. But once you learn it, you've got a skill that nobody's gonna take away from you. And you can apply under any situation when there is no other way to find a blood vessel. If anybody's interested in learning how to start IVs with the ultrasound, I'm happy to teach anybody. The best way to learn and the best way to start is to start doing it on easy patients, right? When you can see the veins, so you can relate to what you are seeing or feeling from the outside, and figure out how to visualize the needle, how to enter the blood vessel, how to advance it when you are there on easy patients that you would be able to do otherwise. So you develop a sense for how to handle the ultrasound probe, how to advance your needle, how to kind of recognize that you're in the blood vessel, how to see that's only the metal tip or versus the plastic tube or anything else inside a vein, and practicing on easy patients. Because if you only pull this machine when you have a tough one, right, it's not gonna work. It's not gonna be helpful. But if you had placed like 10 IVs with the ultrasound, and now you have a tough one, now you can apply all of those skills. Yeah, okay. So, any questions about the ultrasound machine? Remember, the easiest way to see what you are looking at is the potty knife. Put it in there, and you look at the shiny part of the potty knife, and that's on the screen, right? Any questions about the ultrasound machine? Basically, could go on and on, but that's pretty much. Once you know where where the brightness button is, the gain button that is, the depth, the time gated switches are lining up like this, and they are not all over the place. You can use it. It's not there's nothing you can ruin on this machine. And the other one, the logic is exactly the same, except it is a touch screen, right? It is a touch screen structure. Doppler flow could be very useful when there are questions about blood flow, right? Sometimes when we do biceps repair, sometimes that can happen even after total joints. There is a question whether the artery was lacerated, tied, or damaged. We can see distally if there is any flow there very easily, very, very easily. So that's a very useful. You can also use it to see bladders better than the bladder scan to see if there is any bladder distension or how much urine there is. It's an easy tool to use. All right, so that we talked about the frequency. Again, it is built by the size of the crystals. Typically, the larger the crystals, the lower the frequency is, and this is why, to find babies you need a 1 megahertz probe, not a 12 megahertz probe, because it's not a good enough resolution. how you hold the probe, that takes some practice, right? You have to discipline yourself when you're looking for structures, how you are holding the probe and how you move it. Initially, that was the most common mistake for residents when they learned how to do this. They started to use it like stirring, tomato soup all over the place. Now you have to discipline yourself that you move the probe only one direction at a time, right? So when you're looking for structures, like you know that somewhere nerve is running here, you put the probe perpendicular to the structure you're about to scan, and you only move it sideways. Right? You move it sideways, look at the image, and you are hoping that you're going to be able to see it. But once you find it, you center the structure very center of your screen, and this is the time to optimize the image. That's when you apply a little bit more pressure and tilt the probe a little bit, cephalate caudate, and that's how you are going to optimize your image. And that's when you may touch the machine to increase the gain, to change the focus, to basically get the best possible image. When we are doing nerve blocks, we are always going after the best possible image. Because if you have the best image, then you got the best chance to have a good quality nerve block. What's that? Okay, thank you. Depending on how we are driving the needle relative to the probe, most of the time we are using the long axis view. In other words, we are driving the needle parallel to the probe. Why is it is a better and a safer way to do this? Because from the point you are entering the tissues, right, you see the needle tip. You see your target, you see your needle, and you're driving the needle over the target, right? Trouble is, you're trying to drive the needle in a less than 1 millimeter wide plane. Initially, it's just not gonna happen. No matter how much you wanna do this, it's just like, even if you're gonna be the best sharpshooter with time, you're not gonna be able to do 10 bullseye one after another. So it takes a lot of finesse to see the needle in that 1 millimeter plane. You guys are used to it, we're doing it 2 seconds in and out, we are done. But we've done tens of thousands of these. When you see young guys coming in and trying to do it the first time, right, that's a humbling experience, how many times they have to practice before they can see the needle. And lots of tricks, to avoid that they're driving the needle without seeing the actual needle tip. For IV access, it is better to use the out of plane technique. In other words, you are approaching your target from the side. Now, obviously, when you are passing your needle through the probe, you can only see one bright spot, and you don't know where the tip is. You just see that some kind of an object is passing through your ultrasound beam, and then you find the tip, and when you're advancing your needle, you have to advance the probe the same distance as you do it with your needle. So you really have to have a perfect synchronous movement with both hands, so you keep your ultrasound beam focused on the tip of the needle when you are doing all the IV access. It is extremely useful that all days when you use the non-ultrasound guided nerve blocks, right? Once we found the right stimulation current, everybody was yelling at the patient, don't move, don't move, don't move, right? Because from the amount of current it took to stimulate the nerve, we knew that we were close enough to the nerve, right? And we pumped in a truckload of local anesthetic, and if it didn't work out, there was no way to going back. With the ultrasound, that's never a problem, right? Because if the block is not perfect or is no perfect spread, you can always go back and complete the block and cover the nerve with local anesthetic. And also frequently you do small amounts at a time, and you deposit around your nerve until you get a nice and perfect coverage of the neural structure. And it's also very helpful because we always talk about local anesthetic toxicity. That's the single most feared complication you can have when you're injecting large amounts of local anesthetics. This is why we sign out how much drug you can use in the operating room, because there is only how much local anesthetic the human body can handle. Above which, it starts affecting the heart and the brain, right? With the ultrasound, we can do this so precisely, and we never inject large amount of medication at a time. So even if we inject that 2 or 3 cc's of 0.5% Narcan into a blood vessel, unless it's up in the neck and we're injecting directly into the artery, you're not going to see anything from that, right? Maybe a little bit of buzz, and you inject them local and you don't see it spreading on your skin, you know that. So if you look at the tip, right, and you're injecting your local anesthetic, and you don't see it spreading, you either are not looking at the tip, but it doesn't happen to us because we do this a lot, so we know what we're looking at the tip. When your needle tip is sitting in a blood vessel, and the blood vessel carries the local anesthetic away right away. That's why you don't see it spreading. And you stop there. Okay, it's a blood vessel, move it somewhere else. And typically when you aspirate, that means aspirate a little bit of blood, not the end of the world. You just move to a different spot and inject more. When it doesn't work, right, those are the possible mistakes people can make. Even for us sometimes, remember, Gossan, take a look at this, take a look at that, particularly big patients. What am I looking at here, right? That was the biggest revelation we had from using the ultrasound for humans, to recognize the endless number of individual variations, what's happening on the inside, right? My favorite example, I always say to the patients, we all have 2 eyes, 2 ears, 1 nose, and 1 mouth, yet everybody looks different in this room, right? So why do you think that inside the human body, it doesn't follow the same pattern? It's exactly the same, right? So it has to be there somewhere, but it may not be at the location where the textbook describes. It may have 2 branches there, but the ultrasound helps us, identifying them. With less experience, sometimes you go after the wrong target, and this is why you're not gonna see that nerve block. Sometimes just a thin membrane between the local anesthetic and the nerve is enough to block the local anesthetic from getting to the nerve. That's poor needle positioning, and you're not looking at the tip, and you put local anesthetic everywhere, but not around the target. Wrong compartment when we are in the compartment. When you do popliteal blocks, those nerves are wrapped around like a shrink wrap with a thin membrane, unless you lift it off. You're never going to see, it looks like, I give you a picture, oh, it's a perfect nerve block. No, you still have a membrane, a barrier, and that patient has zero block there. So this is why it's very, very important during the block to see what we are doing there. Nerve stimulation versus ultrasonic guidance, clearly this is way better. This is what everybody's doing here. Sometimes when it comes to medical malpractice, and that's going to be the last sentence, and it's continue. People do nerve stimulation with the ultrasound guidance just to prove that they are double correct. For instance, when we are doing the pang blocks for the hips, right? That's a wide field block. We are not looking for any kind of a nerve structure there. You just drive the needle down to the pubic bone, touch it, pull it back a little bit. When the needle is sitting between the iliopsoas muscle tendon and the bone, then we deposit 20 cc of local anesthetic in that layer. And for certain patients, the entry site where you come in from the lateral side, the femoral nerve runs way more lateral than it should be. And people, without even looking at the nerve, they go through the nerve multiple times and they damage the nerve. When you damage that nerve, that person is not going to hold for a long time, or perhaps for forever. And it frequently ends up going to the court. So when I'm doing these blocks, the first structure I find, even if I'm not interested in that, is the femoral nerve. And then I know that, okay, this is very trans, I don't even want to get close to this spot. So I know that I have to go lateral to that one. But if you document, for people who are not doing that many blocks and not as experienced in this field that most of the people you see here, they do the nerve stimulator, so if any nerve damage happens, they can prove it they are double careful, even if they made a mistake. Other than that, other reasons for nerve stimulator, there is not much once you figure out how to use this properly. Well, that's in a nutshell, just a quick introduction. We didn't get to images and in a specific nerve blocks. We can talk about it if there's any interest in the future to go through some specific blocks. But I think it was important to go back to the very beginning and understand how this machine works. And don't be afraid to use it. It's very, very useful. It's just you cannot mess it up. And even if you mess it up with tools, we can bring it back and you can use it. And it's extremely useful. IVs, because big patients, when you don't see it, don't feel it, you can always see it. They always have big veins, just too deep for any kind of another examination to find it. Any questions, and I'll be out of your way.
Thank you very
All right,
much.
thank you.
Thank you.